Hi, this is Brian Kim. I'm going to share with you case number 70 in the Best Way to Do Cataract Surgery series. This is a 2+ dense lens with an irregular pupil. This patient denied any trauma, but there's kind of a focal area of iris atrophy as well. And so you're going to see the use of the corneal mark, which will help me to center and size the rhexis in this irregular pupil. So you can see here that there's an area of iris atrophy right there. And I'm not quite sure what that is. She had no history of trauma, no prior surgery. And so we went ahead, and you can see there's an irregular pupil as well. So I'm using a cotton tip to help center the eye. Use a corneal marker, which will help me to center and size my rhexis. Use a cotton tip to stabilize the eye, and I make my paracentesis incision, first on the right side and then the left side. And the incision is parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. I'm injecting some intracameral lidocaine and then some epinephrine. It didn't seem to change the pupil. Go ahead and inject some dispersive viscoelastic to fill the anterior chamber. And this is the triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, just go shy of the angle, and then enter. I use a cannula to stabilize the eye, and after the incision, I push some more dispersive viscoelastic to fill the anterior chamber. I do feel this helps me stabilize the rhexis. So I puncture the central capsule using the teeth to tease the rhexis. Grab the right side of the tear to create a flap. So I'm going around circumferentially. You can see this pupil is a little bit distorted, but I'm using the corneal mark to help guide the size and centration of the rhexis. So again, if you use the pupil, it will be not centered over the pupil because the pupil is distorted. I'm using the corneal mark as a guide to make the rhexis. So this is Capsulorhexis Hydra Dissection technique. I place the cannula out to the contralateral equator underneath the rhexis edge, get a nice fluid wave. You can see the lens starts to come up out of the bag, decompress the bag, point the tip down on the right side, and the lens begins to spin nicely. Again, lately I've been enjoying the decompressing of the bag, and I do feel like this does help with the spinning of the lens. Irrigate the surface of the cornea. Lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. Remove the surface epinuclear material. Place the chopper underneath the epinuclear ridge out to the equator. Place the phaco tip vertically subincisionally, dividing the lens completely in half. That's the double chop. Place the chopper around the right heminucleus, pulling it centrally towards the phaco tip, dividing the right heminucleus in half. That is the cross chop. Using some vacuum, I grasp that first quadrant, place a chopper around the lens piece, crushing it and dividing it, using successive crushing maneuvers to make the pieces smaller and then emulsify the lens piece. I'm making very small movements as I'm dividing the lens piece into smaller pieces and then emulsifying the lens piece. Place the chopper around the second quadrant, pulling it centrally towards the phaco tip, crushing it into smaller pieces, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, dividing that lens piece in half, placing the chopper around the third quadrant, pulling it centrally towards the phaco tip, dividing it, and then using some vacuum to grasp it, pulling it up out of the bag, crushing it into smaller pieces, and then emulsifying the lens piece. Placing the chopper around that fragment from the third quadrant, pulling it up out of the bag, crushing it between the chopper and the phaco tip and emulsifying the lens pieces. Positioning the fourth quadrant in front of me, placing the chopper around the lens piece, pulling it centrally toward the phaco tip, and then emulsifying the lens piece. Placing the chopper around that last piece, crushing it and dividing it between the chopper and the phaco tip, crushing it into smaller pieces and emulsifying the lens pieces. Once all the endonucleus is removed, grasping the anterior part of the epinucleus and it starts to tumble out. Always positioning the chopper deep to protect the posterior capsule. I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. So in this case, there's a lot of cortical material here. I'm adjusting the sleeve, and I start in the subincisional space, starting with grabbing the anterior portion of the cortical material, sweeping side to side so I can get large sheets all at once. And I'm just going around circumferentially, going back subincisionally, making sure I grasp the anterior component, teasing radially as I do this. There's a little bit of subincisional still left, grasping the anterior portion. It's important to grasp that anterior portion so it comes off as clean as possible. I switch to polish mode to see if I can get it a little bit easier. Now I'm polishing underneath the rhexis edge to remove any lens epithelial cells. After polishing, I go after the subincisional lens material that's adherent to the posterior capsule. So I go in with the BSS cannula into the subincisional capsular fornix and pulsing, and there should be quite a bit of lens material that comes out there. I was able to go after it with the INA handpiece. I'm injecting some cohesive viscoelastic to fill the capsular bag, and then I'm going to polish underneath the rhexis edge on the left side. And then I'm going to polish on the right side. So I'm injecting the single piece acrylic intraocular lens into the capsular bag. The leading edge is going into the bag, and the trailing edge is going to be left out of the bag. So I quickly transition to the INA handpiece, going in with irrigation off, activating irrigation, disengaging each haptic off the optic, going underneath the optic, tilting it and rotating it 90 degrees clockwise, removing all the viscoelastic from within the bag, as well as underneath the lens. Repositing the optic within the bag, polishing underneath the rhexis edge, as well as rotating the haptic in the horizontal configuration, switching to visco mode to remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with an irregular pupil this time. She looks like she had some iris trauma or something in the past. The irregular pupil can affect your ability to get a nice centered and sized rhexis. So as a result, I use a corneal mark always, which will help me to center and size the rhexis. And so this is a clear example of how this is helpful. You can see there's 360 degrees overlap of the rhexis. And this is kind of a standard technique that I do, again, because it's sometimes hard to really size and center of the rhexis, especially in these cases. And so you also saw double chop and cross chop and how I was able to systematically disassemble this lens in this patient with an irregular pupil, as well as a fairly dense lens, average, moderate density, using mechanical fracturing forces to disassemble this lens. So I hope this was helpful to you, and I thank you for your attention.